Assalamu alaikum. This is Dr. Amna, and today's presentation is about genetic factor in ovarian cancer. This is also very important topic because in the part two written exam, and they can give different scenarios of hereditary cancers like BRCA1, BRCA2, and like they will ask BRCA1 carries how much percentage risk of ovarian or breast cancer, and so does BRCA2. And also they can ask that what is the prevention, how can we prevent the developing cancer, and what are the lifestyle modifications, and what involves risk reducing surgery, and when should risk reducing surgeries be done, and what are the lifestyle modifications should be done, and same questions about the Lynch syndrome. These questions can be asked in part two. In the part three exam, they can be whole session about BRCA1, BRCA2, and the Lynch syndrome. As I have mentioned that there can be station that women can give the history of ovarian cancer in the first degree relatives. In that scenario, what should be the counseling? And if there is a patient who comes and say that my friend died with ovarian cancer, so that's why I want to have, I'm scared and I want to have risk reducing surgery. So when there is a patient who is not having family history, what should be advised for that patient? Because the woman who is saying that my friend is having, we must take detailed history of that patient, because we need to see whether she has her own family history or not, because we will not ignore it unless we ask the question whether you have any first degree relative affected with ovarian and breast cancer or colorectal cancers. And then we can tell the patient that is she eligible for, we will refer the patient for genetic counseling, and we can say whether if she is eligible for screening or not. And if she's not eligible and she's still worried, we will ask her to see the counselor, so that because she's very anxious and we want to reduce her stress level, and we will tell her that she can have this test in private, can request it in private setting, and where it will cost almost £1,000. And then we will say that she can, we will tell her the warning signs of the cancers, and she can be involved in the screening, and how can she have the protection against these cancers. And we will tell that if she goes for this genetic testing in private, because she's not eligible to have it in the NHS setting, and if it comes positive in the private setting, she will be entitled to having all the services in the NHS when the patient is diagnosed with having any genetic factor for the hereditary cancers. So now we will discuss about genetic factors in the ovarian cancer. So regarding incidence, the lifetime risk in the general population is 1 in 50, 2% risk. And it is estimated at least 10 to 15% of patients with epithelial ovarian cancer have a hereditary predisposition. So a lifetime risk in general population is 1 in 50, that is 2% of ovarian cancer. It is estimated that at least 10 to 15% of patients with epithelial ovarian cancer have hereditary predisposition. And however, up to 15% of cases may be inherited with gene defects, principally by BRCA1, BRCA2, and hereditary non-polyposis colorectal carcinoma groups. This is also called as Lynch syndrome. Each carrying a lifetime risk of 1 in 2 for BRCA1, for BRCA2 1 in 5, and for hereditary non-polyposis colorectal carcinoma group 1 in 10. This rises to 1 in 20, 5% if women have one family member affected by a pathogenic alteration in one of these genes. These are all percentages are questions in the MRCOG Part 2 exams. And even Part 1 exam, they can give these percentages that if one family member is affected, what is the risk of women having cancer, ovarian cancer? It further increases to 40 to 50% if two first-degree relatives are affected. Hereditary cancer usually occur around 10 years before sporadic cancers and are associated with cancers at other sites, particularly of the breast, colon, and rectum. So these are hereditary cancer which usually present at earlier stage. Same in the Lynch syndrome and same in the BRCA carriers. So breast ovarian cancer syndrome. This is about BRCA genetic mutations. The most common hereditary predisposition is breast ovarian cancer syndrome, accounting for 90% of hereditary cancers. This syndrome is caused by inherited pathogenic variant affecting the tumor suppressor gene BRCA1 and BRCA2. Incidence of BRCA1 is 80% and BRCA2 is 15%. In this basically genetic mutation, person is having mutation in the tumor suppressor gene. BRCA-associated ovarian cancers are usually high-grade serous or grade 3 endometrioid tumors that present at an advanced stage and have a poor prognosis. So two things we have known about BRCA cancers, that it present earlier than the sporadic cancers, and it usually they are at advanced stage and have poor prognosis. Most women in the UK have a 1 in 7, like 15% chance of developing breast cancer in their lifetime. BRCA1 gene mutation carries 65 to 85% risk of breast cancer and 40 to 63% risk of ovarian cancer. And BRCA2 carries 40 to 85% risk of breast cancer and 10 to 25% risk of ovarian cancer. So in BRCA1, there is 40 to 60% risk of ovarian cancer. And in BRCA2, 10 to 25%, because these are gynecological cancer, we are supposed to deal with these cancers. So familial risk screening, women at, we know, now we know what is BRCA and how much it carries the risk. So how we will select the women in the general population who are eligible for screening for these genes. So there can be, we can identify the woman by two things. One is from the family history of the cancer in the first degree relative, or the patient is, patient belongs to the family who has already who has already been diagnosed of carrying that gene. So women at high risk of developing ovarian cancers are defined using genetic testing and from the family history of cancer in the first degree. The purpose of identifying women, why we want to identify these women, because as these women are high risk of cancer and we want to facilitate referral to genetic centers, allow recruitment into research screening programs, and allow discussion for of prophylactic measures. So because we can offer these women that they carries the increased risk, and they should, we will do the counseling and we will ask the patient to complete their family as soon as possible. And when they are done with the family, they have done with their family planning, then we can offer the patient the risk reducing surgery. And what involved in the risk reducing surgery in the BRCA carriers, these are bilateral serpentioophorectomy. And this BSO should be done in preferably in the laparoscopic approach, because always laparoscopy is better than laparotomy, but it requires that the patient is right candidate for this. She's not having any complication from previous cancer, chemotherapy, or she's having any previous complicated surgery, and surgeon is having enough expertise for that. And we know that laparoscopy carries very important part of enhanced recovery program, in which there's early return to the routine life, and there are lesser hospital stay without compromising the patient safety. So women who carry a germline pathogenic variant in one of the BRCA genes are offered risk-reducing prophylactic bilateral serpingio-oophorectomy when they have completed their families. This can usually be performed laparoscopically. Prophylactic surgery reduces the risk of ovarian cancer by 90%. So whenever a patient is very anxious and she says that I want to have bilateral salpingo-oophorectomy so that I will be assured that I will not have cancer in the future. So we will counsel that patient that these prophylactic surgeries can reduce the risk of ovarian cancer, but it does not completely eliminate the risk of primary peritoneal cancer. That primary peritoneal cancer can arise, still there's a chance. It is important to carry out risk-reducing surgery prior to age-related surge in ovarian cancer observed in BRCA pathogenic variant carriers, which is younger in patient with a variant in BRCA1, so mid to late 30s. So there is a surge for developing ovarian cancer in BRCA1, mid to late 30s. And then in those with the BRCA2 variant, mid to late 30s. So we will, when we will do this surgery, depend upon the type of mutation and whether patient has completed the family, and we will make this decision by having a discussion with patient and the preference of the patient and telling her all the risk involved with delaying the surgery. Another suggestion for risk reduction builds on the theory that BRCA-associated ovarian cancer originate in the fallopian tube, as we have discussed in the ovarian cyst presentation as well. So one thing is that we will remove both ovaries and tubes. Another suggestion is, but this is still under research, that we will remove, as most cancer arise from fallopian tube. So first we will remove the fallopian tube in the early phase when the patient has completed the family. So we will remove the tubes, but we will leave the ovaries for some more time because we want the person to have benefits of ovarian hormones. So we can remove the ovary in the later stages, but this technique is still under research. So another suggestion for risk reduction builds on the theory that BRCA-associated ovarian cancer originate in the fallopian tube. Therefore, performing bilateral salpingectomy in the carriers in their 30s and early 40s, followed by delayed oophorectomy at a later age, may offset the morbidity associated with the surgical menopause while reducing their risk of cancer. This strategy has yet to be subjected to rigorous testing and its efficacy is unknown. Recent data indicate that the opportunistic removal of fallopian tubes during hysterectomy for benign indications reduces ovarian cancer risk in women at average lifetime risk of ovarian cancer. So, as I have mentioned in the previous videos, that it's always whether you want to remove the ovary or not in some benign indications. But this can be the matter of debate. But fallopian tubes should always be removed because it can reduces the risk of ovarian cancer. So women who have their ovaries removed before the menopause not only dramatically reduce their chances of developing ovarian cancer, but also reduce their chances of developing breast cancer by up to 50%. So the group of women who are having hereditary cancer related to breast and ovaries. So when you remove the ovaries, so hormonal element is reduced in the woman, and there's a breast cancer risk also reduced. And now, what information else the patient need? We will discuss about the chemo prevention and lifestyle modification. There is a very important point that now we want the patient to complete the family, but we will tell the patient that she can transfer this gene to her offspring as well. So what will we tell the patient regarding family planning? So this is for the patient. That we can tell the patient, have your children without any intervention and risk your child inheriting the faulty gene. So there are chances that if she conceive naturally, there's a chances that her child can carry the faulty gene. And there's another option of adopting a baby or use donor eggs or donor sperm, depending on who carries the faulty gene, to avoid passing on to the faulty gene. Discuss prenatal testing with your doctor, but testing an unborn baby for genes that may cause cancer in later life using CVS or amniocentesis is not routinely offered. So we do not offer, NHS do not offer CVS and amniocentesis for this indication, that we want to screen child for the mutations, cancer mutations. She can have the option of pre-implantation genetic diagnosis. She will be sent for in vitro fertilization, and when they can select the embryos which do not have this mutation, and they will take healthy embryos, and they will implant in these embryos in the mother. But this is in the pre-implantation genetic diagnosis, a technique used to select embryos that have not inherited the faulty gene. But there is no guarantee this technique will result in a successful pregnancy. The NHS and NHS funding for it may not be available to all patients. These are the risk-reducing surgery, and we have discussed the fertility issues with the BRCA carriers. And now, what else can benefit them? Like other procedures that associated with the risk reduction include tubal ligation, because I have mentioned before, the tubes once closed or removed, then they reduce the risk of ovarian cancer. So include tubal ligation or hysterectomy with ovarian conservation. And annual breast screening by mammogram and MRI scan will be done. Chemoprevention for the ovarian cancer. Chemoprevention using the combined oral contraceptive pill reduces ovarian cancer risk by up to 50% in both, and who are both BRCA pathogenic variant carriers and the woman at average risk of ovarian cancer. So combined oral contraceptive pill is protective for both BRCA patient, carriers and normal patients, normal women. Screening using for screening for the ovarian cancer, as I have mentioned before, that ovarian cancer is not having very good screening profile. So screening using TVS and CA125 measurement has not been shown to improve survival. But we will tell the woman if she develops irritable bowel symptoms after the age of 50, then there's more chances that these are not the benign things, and she's having bloating and irritable bowel. And if there's also an in TVS we observe there is a variances, there are more chances it's not benign, and she will be referred to cancer pathway. Because the high-grade serous tumors that are associated with BRCA pathogenic variant carrier status, the most lethal ovarian cancer develop rapidly, and most are at an advanced stage before they can be picked up by screening. So screening is not a good option for these cancers, ovarian cancers. So in generally, we will tell the patient that she will improve her lifestyle, and what we mean with lifestyle: healthy exercise, normal BMI, and overall healthy habits, smoking, stop smoking, and less alcohol intake. Overall general health will be, we will tell the patient to keep her general health well. So overall, we will tell the patient what are the decreased risk of ovarian cancer, which factor which decrease the risk of ovarian cancer, and which factors which increase the risk of ovarian cancer. So multiparity COCP reduce the risk of ovarian cancer 50%, tubal ligation, self-injectomy, hysterectomy. And nulliparity, intrauterine device, and endometriosis increase the risk of ovarian cancer, and also cigarette smoking, which increase the risk of mucinous tumors, and hereditary predisposition, for example, BRCA pathogenic variant and Lynch syndrome. There's if their patient is having these genes, there's an increased risk of ovarian cancer and obesity. So this was all about BRCA mutation. Now we will discuss the Lynch syndrome, because Lynch syndrome was also discussed in exam, and patient can come that she is having ovarian cyst. And I have mentioned in the previous videos that for the genetic patient who was expected to have hereditary cancers, so we will refer those patients to the genetic counselor. So then we will genetic counselor will assess the risk of patient of developing cancer. Then we will there are two type of tests for the patient. One are the diagnostic, which are done on the patient who is having the condition, like who is having cancer, and we want to see which gene this patient carries, so we can we will be able to screen her family for this specific gene. And the tests which are done on the normal person who is not having cancer, these tests are called predictive test, because these tests will predict that patient is having some person is having some specific gene mutation, and there's a we can predict that she's having that much percentage of that specific type of cancer. So Lynch syndrome is caused by a pathogenic variation affecting one of the mismatch repair gene. So mismatch repair genes are basically the genes which repair any mutations. So when there's a mutation in this gene, then there can be it can result in multiple cancers. So genes can be mismatch repair genes can be MLH1, MSH2, MSH6, and PMS2. The names I'm taking because these are different genes. So we need to see the person is carrying which mutations, which gene mutation, because with every gene mutation, there is a different a different risk of percentage of risk of specific cancer. One gene can affect increase the risk of one specific cancer and cannot affect the can have less risk for the another cancer. So it's very important to know about these genes. So this for this reason, the when a patient will be sent to genetic counselor, so that genetic counselor will exactly tell the person that which gene is causing which cancer and what should be done for that. So Lynch syndrome, as it is having multiple cancers like endometrial, and there's also small incidence for there's also there's an increased incidence of colorectal carcinoma and also ovarian cancers, and so these are group of cancers basically. So Lynch syndrome, when it's diagnosed in a person, so its counseling will also involve multidisciplinary approach, and its risk reducing surgery will also include multidisciplinary approach, because it's better to remove the to do the hysterectomy at the same time when surgery for the colorectal cancers are planned. So this reduces the risk of multiple surgery in the person. So Lynch-associated ovarian tumors tend to present at earlier stage like BRCA, but this present earlier than BRCA even. So as we have mentioned that BRCA in the BRCA cancer present earlier than sporadic, but in the Lynch-associated ovarian tumor tend to present at earlier stages than BRCA-associated tumors and have a better prognosis. As compared to BRCA, we have told that in BRCA there is a worse prognosis than not sporadic cancers. Lynch syndrome is an autosomal dominant condition closely associated with colorectal, endometrial, and ovarian cancer. Endometrial cancer is often the first cancer that people with Lynch syndrome will have. So Lynch syndrome could be identified earlier if tests are done after the diagnosis of the endometrial cancer. So Lynch syndrome, the most common inherited cancer predisposition syndrome, most up to 95% of individuals who carry a Lynch syndrome positive pathogenic variant are unaware of it. It is the most common, and 95% even people do not know that they have this mutation. NICE supports the universal screening of individual with colorectal cancer and more recently than those with endometrial cancer for Lynch syndrome. So it is recommended by NICE that for all colorectal carcinomas and endometrial carcinomas, those persons will have diagnostic test for Lynch syndrome. Then there comes the issue of the decreased resources. Then we will discuss how can we further narrow down this testing criteria. Women with Lynch syndrome are at increased risk of both endometrial and ovarian cancer and should be offered personalized counseling regarding family planning, red flag symptoms, and risk reducing strategies. There is a well-documented survival advantage for those with Lynch syndrome who are compliant with colonoscopic surveillance for bowel polyps. Early identification of Lynch syndrome can enable the uptake of cancer risks reducing surgeries, including taking aspirin and lifestyle modification. So it's good for the person to be identified as early as possible. So in this way, because these are having a high risk of colorectal carcinoma as well, they will be offered colonoscopic surveillance, and then they can be advised lifestyle modification, and they will be advised to complete their family as well, and they will be prescribed for aspirin, because aspirin reduces the all type of cancer associated, reduces the incidence of all type of cancer associated with Lynch syndrome. The risk of developing cancer depend on several factors, including which Lynch syndrome gene is involved. For example, those with pathogenic variant in the PMS2 gene have lower risk of cancer compared to those with a variant in the MLH1 gene. Risk-reducing surgeries to remove the uterus, ovaries, and fallopian tubes, total hysterectomy and bilateral salpingo-oophorectomy may be considered by some women after they have completed their families. The risk of ovarian cancer from variant PMS2 is not thought to be increased, and the risk of endometrial cancer is only somewhat increased. So for the now, this was general discussion, and now colorectal carcinoma and the Lynch syndrome. Colorectal carcinoma is the most common and lethal cancer seen in the Lynch syndrome carrier. The risk of developing colorectal cancer depend on the affected gene and the sex of individual. Lynch syndrome associated colorectal cancer has an earlier age of onset with a crude median age at diagnosis of 52 years versus 69 years in sporadic disease. Women have a lower penetrance than men, so which means their risk of colorectal cancer is less. Sorry, this is a spelling mistake. Colorectal cancer is less, yet still considerably higher than the general population. The pathophysiology of the Lynch syndrome-associated colorectal cancers make colonoscopic detection difficult because tumor arise from flat adenomas that are hard to detect. Although these are difficult to detect by colonoscopy, but still it's being done. These cancers have a propensity for the right side of the colon rather than rectum or sigmoid. So these are represent early, and these have usually on the right side of the colon, and these are difficult to diagnose on colonoscopy. For the gynecologist, this information should help counsel women undergoing Lynch syndrome testing because the main effect of a Lynch syndrome diagnosis is the need for regular colonoscopies. Risk-reducing gynecological surgeries could be combined with colorectal surveillance or surgery. It is also important to include colorectal colleagues in any relevant clinical communications. Lynch syndrome increases the risk of cancer at multiple sites, and care of affected individual is necessarily multidisciplinary. So risk-reducing strategies, what are the risk-reducing strategies? Ideally, women with Lynch syndrome should be seen at around the age of 25 years by an expert gynecologist to learn about the red flag symptoms of cancer, discuss family planning, and explore risk-reducing strategies. Raising awareness about red flag symptoms empowers women to seek help appropriately. The lifetime risk of gynecological cancer is sufficiently higher to offer total hysterectomy and bilateral salpingo-oophorectomy for women with Lynch syndrome who have completed childbearing. The timing of such surgery is gene specific for MLH1 and MSH2 at 35 years, and for MSH6 at 40 years and PMS2 at 50 years. Preoperative counseling by both a clinical geneticist and gynecologist is seen as best practice. The laparoscopic approach is preferred. This is the same thing because it leads to shorter recovery time, improved short-term quality of the life. However, it can be challenging for women who have previously received surgery or radiotherapy for colorectal cancer. Hysterectomy and bilateral salpingo-oophorectomy at 40 years of age has been shown to be cost-effective strategy. In premenopausal women, bilateral oophorectomy at the time of risk-reducing hysterectomy result in surgical menopause, causing vasomotor symptom. Obviously, you will remove ovaries in young patient. There will be surgical menopause. These vasomotor symptoms are because there is a sudden cut down of the hormones. These are more severe than natural menopause. There can be urogenital dryness and atrophy, and often reduced sexual function, emotional lability, and cognitive decline. It also increases the risk of osteoporosis, cardiovascular disease, and colorectal cancer. So these points in the counseling can be used if the woman who is not having any gene which are associated with the increased risk of cancer, and she is so scared by the death of her friend, and when you take history and you assess that this patient is not having increased risk of cancer, so she still says that I want risk-reducing surgery. So you can tell this patient that if you remove the ovary at this stage, there can be surgical menopause and the severe vasomotor symptom and dryness and atrophy and they are reduced sexual function, and also there can be risk of osteoporosis and cardiovascular disease, and there will be increased risk of colorectal cancer in you as well, because you can say for the prevention of that cancer, you are not at increased risk of there. It leads to, if you do go for the treatment, it further increase the risk of another cancer. Women should be concerned about the benefits of estrogen replacement therapy. So when there's surgical menopause, we can give the estrogen replacement therapy, ideally by transdermal application for a quality of life and future health. As I mentioned before, that there is no absolute contraindication for HRT. We can give one way or another. We can give transdermal patch. We can give local. We can give or there can be contraindication, absolute contraindication for oral HRT, but not overall HRT. Estrogen has a protective effect against colorectal cancer and does not appreciably increase breast cancer risk. Women with Lynch syndrome should be encouraged to explore other ways of addressing their cancer risk. The risk factor for endometrial cancer in the general population include age, obesity, type 2 diabetes mellitus, nulliparity, early menarche, late menopause, and tamoxifen exposure. And tamoxifen we have discussed in detail in the endometrial hyperplasia. So taking aspirin has been shown to reduce the risk of all cancer types in Lynch syndrome carriers. Aspirin can be given even from 18 years of age. It can be given. Although taking aspirin has its own pros and cons, like there can be peptic ulcer and bloating and all the problems associated with the side effects of aspirin. Aspirin appears to reduce endometrial cancer risk in obese women with Lynch syndrome compared with non-obese women. Lifestyle factors may also affect cancer risk in Lynch syndrome carriers. Smoking, alcohol, increased BMI, increase the risk of colorectal cancer in individuals with Lynch syndrome. It would seem sensible for women with Lynch syndrome to get a healthy diet, maintain a healthy weight, take regular exercise, avoid smoking, cigarettes, and either abstain from or reduce alcohol intake to moderate level. Then comes the pre-implantation genetic diagnosis, as we have mentioned in the BRCA carriers, that this can be, we can tell the patient that this is autosomal dominant condition, and carriers of Lynch syndrome have a 50% chance of passing on the defective MMR gene to their children. So same thing that if they conceive naturally, there's a risk of transferring this defective gene to in the 50% chances of passing the defective gene to the children. And then they can have the option of adoption and donor sperm or donor egg, and they can have the option of CVS, which is, we have mentioned that this is not the indication for which CVS and amniocentesis is offered. And then the pre-implantation genetic diagnosis. So this Lynch syndrome is the indication for which pre-implantation genetic diagnosis can be offered. Lynch syndrome is on the list of conditions curated by the Human Fertilization and Embryology Authority, for which those affected can access pre-implantation genetic testing. PGT allows embryos lacking the MMR pathogenic variant to be selected for transfer following IVF. This reduces the risk of transmission, but IVF is a demanding process, and many couples affected by Lynch syndrome prefer to conceive naturally, whatever the risk. Those wishing to conceive naturally should be advised that the risk of endometrial cancer rises sharply for women older than 40 years and may frustrate pregnancy plans that are left too late. There is emerging consensus that all women with endometrial cancer should be screened for Lynch syndrome where resources permit. Indeed, this is what NICE recommends. Where resources are limited, testing can be restricted to those who develop endometrial cancer under the age of 70 years, or where other clinical features are suggestive of Lynch syndrome. For example, a strong family history of Lynch syndrome associated carriers. Thank you so much. If there is any question, please write in comments.